Good day everyone, we are the group 6 and will report about Monobactam and Aminoglycosides. Let us start with the history and nomenclature of Monobactam. History of Monobactam. It is a monocyclic B-lactam antibiotic that was discovered by the fermentation of broth of Nocardia uniformis in 1976. It is characterized by a non-fused B-lactam nucleus which differs from penicillins, cephalosporins, and carbapenems. As you can see in the structures of the B-lactam antibiotics, the difference between Monobactam among the three is that it is not fused to an adjacent ring. Monobactam, sulfazazine and analogous were identified from different microorganisms. Without the isolation of sulfazazine and analogs, Monobactam's antibiotics will not be discovered. None of these natural molecules have proven to be important, but the group serve as the inspiration for the synthesis of aztreonam. Aztreonam. It is the first class of drug under Monobactam. It is extremely effective against aerobic gram-negative bacteria, including Pseudomonas aeruginosa. But aztreonam is relatively inactive against gram-positive bacteria and anaerobes. Tg-monam. Tg-monam is a newer Monobactam that is orally active. The same with aztreonam, they are not particularly active against gram-positive, but their difference is that Tg-monam is inactive against P. aeruginosa. Nomenclature. The nomenclature of Monobactam are ending with am or am and in or in. In this slide, you can see the drugs under Monobactam and their chemical structures, namely aztreonam, Tg-monam, tabtoxin, and nocardicin A.
At this juncture, I'll be explaining the mechanism of action of Monobactam.
So, as you can see, this is the cell wall of a gram-neg bacteria, and it has three layers: the outer membrane, the peptidoglycan, and the plasma membrane. So, we'll be focusing more on the peptidoglycan layer. Now, recall that peptidoglycan protects the cell from bursting, the bacterial cell. It protects the bacterial cell from bursting, and it maintains the cell shape. This is also where the cell wall synthesis happens, okay, the ring apart. Now, in synthesizing the cell wall, we need enzymes, particularly the transpeptidases. So, on transpeptidase, it is a bacterial enzyme that cross-links the peptidoglycan chains to form rigid cell walls. So, mo yung mga peptidoglycan chains. So, they link them, kaning mga transpeptidase. Ang example sa transpeptidase is this PBP or the penicillin binding protein. Now, kaning PBP or any other transpeptidase, they are essential in peptidoglycan biosynthesis or cell wall synthesis because without them, the bacterial cell wall will lose its rigidity, killing the bacteria because it will compromise the integrity of the cell wall. So yun, mamatay ang bacteria. Now, Monobactams works just like the other beta-lactam antibiotics. Why man? Na ganitong mga antibiotics ng beta-lactam, these are penicillins, cephalosporins, and carbapenems. Now, why do they work the same? Because remember, they all have their common denominator, the beta-lactam ring. Diba? Now, recall from the report of group 2, this is from their PDF, second page, that the beta-lactam ring daw, it mimics the D-alanine peptide sequence. So, man na? Mo ni ang substrate. This is the substrate kanang D-ala. Substrate ni siya where the enzyme will bind sa ganitong enzyme, the transpeptidase. So, when these two binds, ang may tabo, it will produce binding sa peptidoglycan or polypeptide chain, making the cell wall rigid. Now, the beta-lactam ring, it mimics the structure of the ala. So, if diri magbind ang enzyme katong transpeptidase, it will inhibit the cell wall synthesis. Cell wall synthesis. So, monobactam works by binding sa PBP. Mo yang monobactam. So, it will bind sa PBP, which will inhibit the cross-linking kanang connection bitaw kaning connection nila. It will inhibit the linking of the polypeptide chain. Ma-inhibit na tayo ang cell wall synthesis. This will result to cell rupture or lysis, cell lysis or cell rupture, hence killing the bacteria. That is why monobactam is classified as bactericidal or bacteria-killing drug kay kato. Mabuto ang cell sa bacteria.
So here is a summary of what I've explained earlier. Again, monobactams work by binding to PBP and then inhibiting the cross-linking of different peptidoglycan chains, suppressing the cell wall synthesis, resulting in bacterial cell lysis or rupture.
Monobactam drug examples: Aztreonam, totally synthetic parenteral antibiotic whose antimicrobial spectrum is devoted almost exclusively to aerobic gram-negative microorganisms, and it is capable of inactivating some beta-lactamases, given by injection and is primarily excreted in the urine. Use of Aztreonam is for severe infections caused by gram-negative microorganisms, especially those acquired in the hospital. These are mainly infections in the urinary tract, upper respiratory tract, bone, cartilage, abdomen, obstetric, and gynecologic regions. Also, it can be used to treat septicemias. Adverse effect. The drug is well tolerated and adverse effects are infrequent. Side effects: nausea, vomiting, diarrhea, stomach pain, redness, irritation, or swelling at the injection site. Precaution: stop using this medicine and check with your doctor right away if you or your child develop a skin rash, hives, swelling of the face, tightness in the throat, or any allergic reaction to Aztreonam. This medicine also causes bronchospasm. Toxicity: there is no evidence that Aztreonam causes significant ototoxicity or nephrotoxicity. Biochemical and hematologic abnormalities are rarely significant. Compared to the broad-spectrum cephalosporins, Aztreonam causes less disruption of normal gastrointestinal flora and consequently a lower incidence of diarrhea.
Trigeminum. It exhibits good potency against H. influenzae and N. gonorrhoeae. It is highly resistant to beta-lactamases. Therapeutic application. For the oral treatment of urinary tract infections and other non-life-threatening infections caused by beta-lactamase-producing gram-negative bacteria. Adverse effect: skin rash and occasional abnormal liver functions.
Aminoglycosides and aminocyclitols. History. Antimicrobials called aminoglycosides were initially identified from actinomycetes in the 1940s. Streptomycin was the first aminoglycoside to be used in the treatment of tuberculosis. It was isolated from Streptomyces griseus. In 1952, Selman Waksman, the first to invent the name antibiotic, shared the Nobel Prize for Medicine with Albert Schatz, who was later recognized as a co-discoverer. Since then, a variety of aminoglycosides have been identified as products of Streptomyces, like neomycin, kenomycin, tobramycin, or micromonospora, like gentamicin, sesomycin species, or generated by chemical alterations of known aminoglycoside scaffolds, like amikacin, nitylmycin, arbicacin, and plazomycin. Plazomycin is the first aminoglycoside to be licensed by the FDA since amikacin in 1981, and it was created to overcome aminoglycoside modifying enzymes, or AMEs, the most common aminoglycoside resistance mechanism in Enterobacteriaceae. Aminoglycosides bacterial targets are the gram-negative aerobic bacilli, like E. coli, Klebsiella, Proteus, and Pseudomonas. In Pseudomonas, it is known that tobramycin has a greater activity to Pseudomonas than gentamicin. It is very important that aminoglycosides are only used in gram-negative aerobic bacilli and not used for gram-positive aerobes. Furthermore, they are not useful for anaerobic bacteria. The aminoglycosides nomenclature, whether ending with mycin or mycin, depends on which microbe they are derived from, Streptomyces or Micromonospora. When we say thermycin, it is not an aminoglycoside because antibiotics with the suffix thermycin are the macrolides, like azithromycin and erythromycin. These are the examples of drugs that ends with mycin that are derived from Streptomyces. Kanamycin, also known as Cantrex, neomycin, spectinomycin, streptomycin, and tobramycin. And drugs that ends with mycin are derived from Micromonospora, amikacin or amikin, and gentamicin. Various aminoglycosides antibiotics are freely water-soluble at all achievable pH, are basic and form acid salts, and are not absorbed in significant amounts from the gastrointestinal tract, and are excreted in active form in fairly high concentrations in the urine following injection. Patients with kidneys that are not functioning efficiently, the dose must be reduced to prevent accumulation to toxic levels.
The route of administration for the aminoglycosides. Orally, it will confine to the GI tract, topically as solutions or ointments for ophthalmic infections, and parenterally, intramuscularly but more delivered by IV fusion. Aminoglycosides mechanism of action. Aminoglycosides are bactericidal due to a combination of toxic effects. Their primary site of action seems to be located in the bacterial ribosome system. They bind to the 16S ribosomal DNA component of the 30S ribosomal subparticle, impairing the proofreading function of the ribosome. The uptake process is inhibited by the calcium and magnesium ions. These cations are responsible for cross-bridging and stabilization of the lipid components of the bacterial membrane, and the removal leads to the disruption of the outer membrane, enhanced permeability, and initiation of aminoglycosides uptake. Basically, in very simple terms, we can say it's a protein synthesis inhibitor. For the inhibition of protein synthesis in a bacteria, of course, there are two different subunits of ribosomes, 50S and 30S subunits. The mRNA that is present in ribosome is sitting there at a 50S unit and the 30S unit in green. But what happens if there is any type of aminoglycoside antibiotic present? It can do the three different effects. First, it can block the initiation of the protein synthesis. Second, it further blocks translation and elicits premature termination of the non-functional protein. And lastly, the incorporation of the incorrect amino acid that allows the misreading of the mRNA by the ribosome to add incorporation of incorrect amino acid, which will ultimately lead to the formation of truncated proteins. A conformational change occurs in the peptidyl A site of the ribosome upon aminoglycoside binding. This leads to mistranslation of RNA templates and the selection of wrong amino acids and formation of so-called nonsense proteins. Overall, when there is a presence of aminoglycosides in the 30 subunit of the bacteria, the tRNA will misread the codon, causing the tRNA to bring the wrong amino acid to the polypeptide chain, and in turn, it won't produce the protein that bacteria need to survive, which will eventually lead to the destruction of the bacteria, killing themselves.
Amikacin or amikin is used for treatment of sensitive strains of Mycobacterium tuberculosis, Yersinia toleransis, and severe Pseudomonas aeruginosa infections resistant to other agents. It can be administered parenterally or via nebulization. Precaution: amikacin can pass through breast milk and the placenta. Even though only small amounts pass into breast milk, Experts do not recommend breastfeeding while on amikacins. The drug can cause renal and auditory toxicity in combination with other drugs that have the potential to cause renal or auditory toxicity. In general, amikacin is not used for infants. Amikacin is excreted in human milk for those who breastfeed their babies, and for elderly people it is excreted by the renal route. Renal function should be assessed whenever possible and dosage adjusted as described under impaired renal function. Amikacin diffuses readily through extracellular fluids and is excreted in the urine unchanged, primarily by glomerular filtration. It has been found in pleural fluid, amniotic fluid, and in the peritoneal cavity following parenteral administration. Its pharmacokinetic is that the amikacin plasma elimination half-life is usually 2 to 3 hours in adults with normal renal function and is reported to range from 30 to 86 hours in adults with severe renal impairment. And its resistance, the main amikacin-resistant mechanism found in the clinics, is acetylation by the aminoglycoside 6N acyltransferase type IB, an enzyme of gram-negative bacteria. So if acetylation occurs, it will prevent subsequent ribosomal binding. On its toxicity, no antidote for toxicity is available. Only 20% dialyzable. Avoid potentially toxic prolonged peak concentrations above 35 micrograms per milliliters. Its adverse effects are nephrotoxicity. It's the most common, occurring in 1% to 10% of patients. Renal damage is more likely to occur in dehydrated patients, have a lower glomerular filtration rate, have diabetes, sepsis, fever, or are NSAIDs or NSAIDs. Second is ototoxicity. Vestibular and auditory, 4% to 6% can occur when using high doses. The patient may complain of loss of balance and hearing loss, which can be permanent if drug therapy continues for prolonged periods. And lastly is the neuromuscular blockade, is the less common one.
Gentamicin, garamicin. It is a mixture of several antibiotic components produced by fermentation of Micromonospora purpurea and other related soil microorganisms. It is one of the first antibiotics to have significant activity against Pseudomonas aeruginosa infections. It is used for urinary tract infections, burns, some pneumonias, and bone and joint infections caused by susceptible gram-negative bacteria. Its common adverse effects are vertigo, imbalance, ataxia, oscillating vision, hearing loss, and tinnitus. Gentamicin resistance. The penicillin or vancomycin and gentamicin combination is synergistically bactericidal against enterococcal strains that exhibit low-level resistance to gentamicin, while strains that exhibit high-level resistance are unaffected. Pharmacokinetics. Gentamicin is rapidly absorbed after intramuscular injection. Peak serum levels are usually achieved within 30 to 90 minutes and are measurable for 6 to 8 hours. Gentamicin does not appear to be metabolized. Gentamicin is excreted almost entirely by renal glomerular filtration. Gentamicin poisoning or toxicity, kidney damage and renal failure, nerve damage, ototoxicity, damage to the ear, such as hearing loss, vertigo or ringing in the ear or tinnitus, balance problems, problems with memory, concentration, and fatigue, oscillopsia or bouncing vision. Precautions. Using this medicine while you are pregnant can harm your unborn baby. This medicine may cause serious allergic reactions, including anaphylaxis. Stop using this medicine and check with your doctor right away if you or your child have sudden decrease in hearing or loss of hearing. Do not take other medicines unless they have been discussed with your doctor. Gentamicin may cause nerve problems.
Kanamycin contracts isolated from Streptomyces kanamyceticus, among the most chemically stable of the common antibiotics, along with gentamicin, neomycin, and paromomycin. It is used parenterally against some gram-negative bacteria, but usually resistant to Pseudomonas aeruginosa and anaerobes. It can also be used in combination with other agents against certain mycobacteria such as rifampin, streptomycin, amikacin, and azithromycin to prevent the mycobacteria from becoming resistant to any one medication. Pharmacokinetics of kanamycin contracts. The drug is rapidly absorbed after IM injection or IV injection, and the peak serum levels are generally reached within approximately 1 hour, in which the serum half-life is 2.5 hours, and it is excreted through renal excretion that is extremely rapid since it is not reabsorbed by the renal tubules, and excretion is complete within 24 to 48 hours. Kanamycin contracts should not be used as a long-term treatment. It is contraindicated in patients with hypersensitivity. It can cause ear damage, kidney damage, and paralysis. And caution should be exercised in patients with history of dehydration, brain nerve damage, myasthenia gravis, Parkinson's disease, and kidney failure.
Taubromycin is one component of a mixture produced by fermentation of Streptomyces tenebrarius. It is used parenterally for difficult infections, especially those by gentamicin-resistant Pseudomonas aeruginosa. It is used to treat certain serious infections that are caused by the bacteria, such as meningitis, and infections of the blood, abdomen, lungs, skin, bones, joints, and urinary tract. Special precautions. Before using taubromycin, tell your doctor if you are allergic to taubromycin injection or other aminoglycosides, or if you have an inherited condition that affects the lungs and digestive system, problems with your muscles such as myasthenia gravis or Parkinson's disease. And if you are having surgery, including dental surgery, tell the doctor or dentist that you are using taubromycin injection. Taubromycin is not appreciably metabolized. Taubromycin is primarily excreted unchanged in the urine. Taubromycin has an apparent serum terminal half-life of 2 to 3 hours, and 90 to 95% is being excreted in the urine within 24 hours for those who have a normal renal function. And for its resistance, the majority of gentamicin-resistant Pseudomonas and Acetobacter species were also taubromycin resistant, according to a study published in the Journal of Clinical Biosciences. Its adverse effects are rash, peeling or blistering of the skin, itching, hives, swelling of the eyes, face, throat, tongue or lips, difficulty breathing or swallowing, and hoarseness of voice. If you experience a serious side effect, you or your doctor may send a report to the FDA or the Food and Drug Administration's Midwatch Adverse Event Reporting Program, online or by phone.
Neomycin. Neomycin is a mixture of 3 compounds. These are neomycin A, neomycin B, and neomycin C, produced by the fermentation of Streptomyces preidae, with neomycin B predominating since it is the most active component. It has various routes of administration. In oral administration, it is used for the suppression of gut flora in preparation for bowel surgery. Neomycin is often combined with erythromycin a day before the surgery to decrease the bacterial load in the colon to reduce the possibility of surgical site infections. In topically administered, which is the alternative preparation of neomycin, it is used in the treatment of bacterial skin infections. Pharmacokinetics of neomycin. Neomycin has a poor gastrointestinal absorption, in which the small absorbed fraction of neomycin is excreted by the kidney, while the unabsorbed portion of the drug is excreted unchanged in the feces. Precaution and toxicity. Neomycin now has a black box warning related to systemic toxicities. This includes nephrotoxicity, ototoxicity, neuromuscular blockade, and respiratory paralysis, concurrent use with the other aminoglycosides and potent diuretics due to absorption in ulcerated or denuded areas of the gastrointestinal tract. Neomycin should also be avoided in patients with myasthenia gravis because it might worsen the chronic autoimmune disorder of the patient. Side effects of neomycin are nausea, diarrhea, Clostridium difficile-related colitis, and the serious adverse effects are nephrotoxicity, auditory ototoxicity, and vestibular ototoxicity, which is usually irreversible. Streptomycin. It is produced by fermentation of Streptomyces graeus and several related soil microorganisms. It is used in the treatment of tuberculosis but rarely used today as a single agent, so it is used in the combination with the other agent such as isoniazid, rifampin, and pyrazinamide. Note that resistance to streptomycin takes the familiar course of N-acetylation that catalyzes the acetylation of an amino group, O-phosphorylation that catalyzes the phosphorylation of a hydroxyl group, and O-adenylation that catalyzes the adenylation of a hydroxyl group of their specific functional groups, preventing subsequent ribosomal binding. Pharmacokinetics of streptomycin. Streptomycin is poorly absorbed within the gastrointestinal tract and is typically administered parenterally via deep intramuscular injection, and in some cases may be administered intravenously with a peak serum concentration of 25 to 50 microgram per ml is achieved within 1 hour after IM administration of 1 gram of streptomycin. Approximately 50% of streptomycin is eliminated in the urine within 24 hours after IM or IV administration. Half-life is estimated to be 2.5 hours. Precaution and toxicity. Streptomycin is contraindicated in patients with known renal impairment, which directly links to their inability to excrete streptomycin at the same rate as individuals with normal renal function, and also contraindicated in pregnancy due to its ability to cross the placenta in combination with its known ototoxic effects that can cause deafness. Thus, caution must be exercised when combining streptomycin with other potentially ototoxic drugs. Adverse effects of streptomycin is hypomagnesemia, in which the amount of magnesium in the blood is below the normal during long-term treatment, which can cause also seizures and encephalopathy in extreme cases in which it is a disease that affects the brain.
Spectinomycin tropicin, unusual aminoglycoside antibiotic produced by fermentation of Streptomyces spectabilis, bacteriostatic as normally employed. Second choice treatment of gonococcal infections. The diamino-inositol unit spectinamine contains two mono and methyl groups, and the hydroxyl between them has a stereochemistry opposite to that in streptomycin. Resistance of spectinomycin is due to enzyme which inactivate the drug by adenylation. At least two major groups of adenylyl transferases, AAD, also known as nucleotidyl transferases, ANT, are involved in spectinomycin resistance. Therapeutic application. Spectinomycin almost exclusively used in a single bolus injection intramuscularly against Neisseria gonorrhea, especially penicillinase-producing strains in cases of urogenital or oral gonorrhea. Useful for the treatment of patients allergic to penicillin and patients not likely to comply well with the medication scheme. Pharmacokinetics. Absorption is poor via the oral route in humans and in animals, but rapid and extensive after intramuscular injection. Spectinomycin is not extensively bound to proteins either in serum or in milk. Plasma elimination half-lives range from 1 to 3 hours in various species, like sheep, cattle, dog, and man, when administered via the oral, intramuscular, and intravascular routes. Spectinomycin is rapidly and extensively excreted in the urine and is not metabolized in animals or in humans. Spectinomycin precautions. Avoid excess dosage. Caution should be exercised in patients with history of liver or kidney disease, any allergy, who are taking other medications during pregnancy and breastfeeding. Avoid long-term use of this medication, otherwise it may cause secondary infection. It may cause dizziness. Do not drive a car or operate machinery while taking this medication. Toxicity. Acute toxicity to rats and mice. Information on overdose in humans is not available. Adverse effect. Hypersensitivity, hypomagnesemia with long-term treatment, seizures, and encephalopathy in extreme cases.